All right, folks. Again, thank you for attending. We're here because many of the Ocean Shores residents are a little frustrated by the lack of quality health care. And we've asked these people sitting up front if they please come and talk to us. And what we're going to do is give each person 2, 3, 4 minutes to explain who they are and maybe where they come from, where they're going, and then we'll go ahead and start our questions. So would you like to start? Okay.
Can you hear me? Is that good? I'm Lynn Cernata, and I was elected the hospital board commissioner in 2019, end of 2019, and started my 6-year term. I'm for the North Beach District, which is Pacific Beach, North Beach, and of course the Ocean Shores. Let me see, I'm a registered health information administrator. That's a 4-year degree in health information management. So I used to run medical record departments in hospitals. Then I was a consultant for a software company and finished out my career there doing project management. I'm retired from that formally, but I work at the Honda dealership part-time and do some other things. And of course, this is one of my focuses, being a commissioner. Let me see what else. I've lived in Washington since 2017. We moved up here from Southern California to start our business, and I live in Pacific Beach, and I have 3 cats and a husband.
Ladies first.
Good afternoon, everyone. I'm Vicki Raines. I'm your Grace Harbor County Commissioner for District 3. I recognize many of you. It's been a while since I've seen you and been in person, so I was actually pretty excited to come out and visit with folks today. I've been a county commissioner. This is my 8th year. I'm in my last year of my current term, and we'll see where things go from there. Previously, I served as the mayor of Cosmopolis for 12 years and city council for 3 years. I live in Cosmopolis, which is part of District 3 as well. And my primary background is in finance with investment planning and insurance planning, as well as risk. I've lived in Washington since 1966, and I have 3 kids and 2 grandchildren that I get to go see this long holiday weekend, so I'm excited. I'm mainly here today to listen. The county commissioners don't have a lot of I like to think that we partner with our public hospital districts that we have, but we don't really have authority over them, but we can, discuss things with them, and I can carry your voice forward in that perspective. But I think that you'll hear from Chairman Bruce and Commissioner Cernata a lot from the hospital and the current perspectives, and then I'm happy to chime in wherever I can.
Good afternoon. My name is Michael Bruce. How many lions do we have in the room? I know we're lions. Dan here. Do we have very many lions?
1.
Just one. The reason I bring that up is I was a long-time lion before I moved to the harbor. I was a district membership chairman for 19H. I've been Lion of the Year, International Award. I've been club president, club secretary. It just makes me feel good to be here again. That's why I brought it up. So I've been becoming the board chairman. It's called the board president, but I prefer to call it just being a commissioner. I was the mayor of Westport for 12 years. What brought me to this area in 2000, I was imported to improve the technology for the Casa School District. And I've taught at all different levels, from elementary through graduate school, community colleges, and so forth. And I've done a lot of grant writing in the past, and worked through a lot of problems. I've been in elected politics in other cities and here, and I think I counted over 20-some years of service. So I know what it's like to work with people and move things forward. And I'm also currently, the last day of being mayor of Westport was December 31, 2015, and I had the general manager of Westport Seafood pull in my driveway and said, "What are you going to do when you're done being mayor?" And I said, "Just be retired like I did when I retired from teaching in 2010. he says, I want you to come to work for me. So I've been working government compliance for Westport Seafood. I work with all government agencies that come through, food safety guide, and all that stuff. So I continue to work with the public and for the public every day.
All right, and if I understand correctly, do we have Tom Jensen on?
Tom Jensen is not via phone today, and the main reason is I conferenced with him this morning. He's been out ill over the weekend, and today was his first day back. And many of our employees at the hospital are wearing several hats, and I think this morning one of them was getting caught up. But we can always call him if need be. Also, the question is, how do we conference on the phone where everyone could hear it? So it's not because he doesn't want to be here or we don't want to bring other people from the hospital. We'll do it another time. So I'm hoping we can answer your questions, but if we can't, we'll make sure we get the information to you.
All right, I appreciate that. By the way, my name is Jan Hyatt, if anyone wants to yell at me for anything. All right, we have several questions that we had prepared in advance, and it'll be their choice up there on the stage who wants to answer, or all three. And then, if there is time later on, if there are questions from the audience, we might be able to get those in also. So we have, we're concerned with medical care here, and we had a question that says Ocean Shores homeowners provide approximately $1 million of tax money each year to the hospitals. Has any of this money been used directly for the benefit of our community? And
Do we raise our hand or do we say it? I can address that pretty easily. First of all, the reason we're a hospital district is we were asking for compensation from our state legislature on helping some funding to keep our hospital thriving and open. And we were told that we're not going to listen to you unless you go to your public first and go to the county. So that's how the hospital district was formed. We put it before the voters. And the taxes that we all pay on our assessment values, it goes directly to help support the hospital. It actually says on the ballot for the hospital. So that's where the dollars go. So all the dollars that all of us pay are utilized every day to keep the hospital open. Totally, all the tax dollars collected from our district account for 4.5% of our total budget. 4.5%. And none of it actually, I'm just saying, all of it goes into a trust fund that helps pay down our reorganized debt for our bonds. But you can see that 3.4% is a lot of money in our organization. So I mean, that question comes up quite a bit. The unincorporated areas actually pay, those that are part of the cities, I actually have that printed out today because I've seen that question asked several times. The unincorporated part pays $1.4 million, and all the cities are broke down of what those tax bases are. And I appreciate that question, but the district was formed to help support the hospital. Keep the level 3 trauma center open.
any other comments? All right. Is there any possibility that Harbor Regional might ever partner with Seymour to bring Ocean Shores an urgent care clinic?
Yeah.
Lance, you're welcome to answer anything. It's a possibility. So I'm going to go back a square. I think I was the mayor of Westport. I told you that, but I live in Westport. We don't have a medical center in Westport. We have a private doctor that has a practice. I would love to have Seymour in our community. I travel 30 minutes at least for a medical appointment myself, and that's if I don't have specialty services require me going to Olympia. And since I've been on the board since 2017, at the end of 2017, I took over an unexpired term, and I ran a time or two after, I forget, that all runs together. But having enhanced medical service in Ocean Shores, it's not off the table ever. It's how do we do it? And I've had this conversation with Mayor Dingler years ago, and Susan C., Connery or Canary, All of these, there's several groups in Ocean Shores always ask the same questions. How are you going to get us medical care and how soon? So to answer the question about Seymour, one of the things that we have talked in the past to groups about is would two different medical centers here survive, Seymour and Harbor Regional Health, if they were to expand here. And so that question comes up, how many people use a Seymour and how many people aren't, and where the people would come from. And Tom, our CEO Jensen, said, that let me contact Seymour and see if they have space available so we could add more services out there. That would be the easiest way to do it because they already have everything needed for a clinic. Other things have come up in the past about possibility of buildings being retrofitted, and there's been several conversations, and it kind of meanders like this. I don't want anybody in this community to think that we don't want you to have a medical center here or encourage a doctor to move here, but the biggest problem is finding the medical providers that come here. And I can talk a little authoritatively about what happens when a private practice comes here. It's kind of like what we have in Westport, where the doctors there were two of them, bought a building to start a medical clinic. And they couldn't afford to do that. So the husband, Mr. Duber, he's the medical director in North Dakota, and he flies back and forth every week to work for a hospital to help fund his clinic. And his wife that runs the clinic only takes so many of Medicare, so many of Medicaid, so many of VA, because they can't overpopulate that with people that aren't full payers, or they can't make a go of it. And when I was the mayor, I was right across the street from the clinic, and she wouldn't see me because I was on Medicare. She already had a Medicaid fulfillment. One of my council members was a veteran on VA. She didn't take VA. She didn't have room for a VA patient. So just because you encourage or you hope a doctor will move into your community, or doctors, is that if they can't make it financially viable, they will not survive as a private practice. And when it comes to starting a medical center, you start counting out how many people it takes, and I don't have that figure of what it takes to run a clinic, but it doesn't take one person, two people, three people. It depends how many days the clinic's open. You need a medical assistant, you have a PA or a doctor. If you have a PA in a facility, it has to have overseeing doctor and so forth. But I don't want to leave here today thinking that you people aren't being listened to, and we've always tried to figure out how to make it happen. And we do what's called a pro forma. We look at what it would cost to open the clinic, what it would cost to serve the clinic, and the sustainability, how many people are going to come. And so, and we haven't done any expansion since I've been on board except trying to fill our spots within our system. And we have many vacancies. And actually, and I didn't come here to sprinkle the crowd with dampness, but this is probably the worst time to try to open a clinic because they're trying to find a medical provider during the pandemic. We've had so many people retired because they didn't want to be around the pandemic or the illness or take it home. We've had people who have done well in the stock market that it's financially viable for me to sit out for 3 years and possibly come back after this is over. There's various reasons, but there's no place you're going to find that's fully staffed. And the other problem is where do the people live that are going to serve your community? And so even as we hire people for our hospital, our Harbor Regional Health, our system, is finding places for them to live and not have to drive from Olympia has always been problematic. Was that the question?
We do have some statistics on the vacancies we currently have in the hospital. If you want me to share those now, or would that be later? Would you prefer to wait?
We have time.
Okay. So right now, we've got these statistics yesterday to make sure we were prepared. How many medical providers, we're talking doctors and physician's assistants, are needed to fully staff our clinics? Currently, we have openings for two pediatricians. We need an OB-GYN, a general surgeon, we need an orthopedic surgeon, we need family medicine nurse practitioners, about 3 of them, so we have a total of 7 openings there. And then how many medical providers, doctors and PAs are needed to fully staff our hospital? Currently, we have openings for a radiologist and 1.5 anesthesiologists. So we have 2.5 openings there. let's see, RNs, as we, if you've been listening to the news, are there's a huge demand for them. So we have 160 total RNs. We need 160 total RNs for the hospital setting, and currently we have 33 openings. And what we're doing to supplement our staffing is we have what's called travelers. And travelers are paid, work for a company. The company hires them into us. They travel here, they work for us, and we pay upwards of, I think, $150 or more for each traveler. And that's that's hard on the hospital, but that's to keep the staffing going. And we do the same things for physicians to staff the ED and to be hospitalists as well. As a matter of fact, when we first moved here, we lived in the Levy Street property. It used to be a restaurant over in Hopeland. And the person who lived below us, he was a doctor here, but he came in every 2 weeks. And he shared a position with Dr. Bruce, Dr. Bruce Worth, sorry, I call him Dr. Bruce. And they shared that position, but he was a traveler, and he ended his travel after 2 years. He went back home. But what I'm trying to get at is there's a huge deficit. And right now, if I can find the article that I was showing you, Michael, it was very telling that...
Look for the taco sauce.
We had tacos. If anybody got to watch the segment on 60 Minutes a couple of Sundays ago, they did a expose on a hospital in Louisville, Kentucky, and they were talking about the deficits in providers. And then I did some more research, and right now, the United States will face a shortage of between 54,100 and 139,000 physicians by 2033. That's frightening. And it's especially even more frightening to those of us who are entering our older years and are requiring more care. I don't know where this care is going to come from. So it's frightening to me to think about that. Rural areas suffer more, and I can speak from a place of, we didn't know if we should move here to open our business, and when we drove into town, it wasn't always pretty when you come in town, but after spending a week here, we love the people. We thought we could make a go of it, and I've enjoyed living here. We've made our roots here, and we're enjoying it, but there's so much more, and I keep thinking, what don't people see about Grace Harbor? There's so much to do here. If you just get here and see what there is to do here, why don't people want to move here? But then, of course, you've got where they're going to live. But I don't mean to belabor this. I'm not trying to give you excuses. I just want to share with you what is going on in the nation. And the issue is, even if we started pumping people into the schools, it would be a good 6 years or more before they're ready to come out and serve us. And the same thing goes with nurses. The Louisville hospital said they were turning people away now because they don't have educators to teach the nurses to get the nurses out there. It's broken, but that doesn't help us answer our questions. So what I'd like to do today is see what we can do. It might not be an urgent care, but what can we do? Is there something that, what are you looking for? Do you want specialists? Do you want more primary care physicians? What is it that you want? And we'd like to hear more from you telling us what you want. If an urgent care isn't possible, what else would work? I do know that we were talking, CEO Jensen is talking with Seymour, and we're trying to gather information from all of you. Do you want specialists? We could put a specialist maybe out here a couple of days a week in Seymour. I think they're open to partnering with us, but we don't know what it is that would help most. If it is a specialist, maybe we can work on getting a specialist out here a couple of days a week. What is it that would serve you first to start with? Because we might have to crawl before we can walk and run. So.
Let me add to those comments. To fully staff our hospital takes 160 RNs, and we're 33 short. And what compounds the problem, not only is the COVID an issue, and hopefully it'll be behind us one day, is the schools that pay the instructors that teach nursing students can make more in nursing and more as travelers than they can as instructors. So they have a hard time finding instructors to train these nurses. Our college here in Grace Harbor has stopped their MA program this year, our medical assistant program. Our hospital and our clinics require on MAs. MAs are when we go to the doctor that take our blood pressure and ask you the questions, and they call them rooming you to the doctor's room, and they do all of that stuff. Well, now we don't have them trained in our own community, and it's becoming problematic. So there's not like one thing that we can solve that'll solve everything. It takes a collaborative effort and a lot of different things working together. And also, Lynn brought this up, the word is called focus, is the community. We all know that you want enhanced medical services here. And what can happen here, what would be the easiest and quickest, and how it would be sustained. And even though you look at grants, and this is all guesswork on my part, because I haven't studied a lot of the grants that are out there, but it becomes problematic for rural health care clinic status if you're within 35 miles of a hospital, which Ocean Shores isn't. And so it takes another act of the federal government to work on that. But anytime, any grant that you work on was going to want to have background information, a pro forma or a boilerplate, and they'll ask you questions about what are the costs to build it, and the bottom line at the end is how is that sustained? And the only way you can get that information is by querying your community. And I don't know whether you have that possibility, like other cities, that you can send on a billing statement for your water and sewer from the city. A lot of times they have ways to do that. I don't know if they have that problem here. They have that possibility here. And the other thing is, how are you going to pay for it? How is it going to be paid for? And in round figures, to build a clinic that has a lab, the x-rays, and the bare minimum is $3 to $4 million for a provider. And if you want something more, then the prices go up. My guess, if I were, and I haven't talked to Mayor Martin about this because I would suggest it, is that there's funds becoming available into the future for more tsunami evacuation and tsunami preparedness. And if a community, I'm just thinking out loud that if a community had that as part of their plan for evacuation, use a lower unit for a medical, whatever you want to call it, a clinic or a care or walk-in clinic, then you know you're going to have funds to build it. Then you have to worry about how to staff it. But that's one way to look at it. But I don't think, there's no way you can just sit there. It's not like going to the bank and applying for money when you do grant work. They want a lot of background work and information to get the information.
And that costs to get.
And it costs. And that's another good point. Most grant writers either want a piece of the action, part of the grant that you receive, or they want to get paid up front. So somebody's got to pay for that. But that's not really a downside, because the upside is once you have that boilerplate of information that you need for a community needs assessment for your community, then it can be used for any grant that you use. So you wouldn't have to pay for it multiple times. There's other ways to enhance health in your community too, but I want to just toss this out there. I look around the room, and a lot of people may be able to identify with this. Growing up, I had the same doctor from the time he started until he retired. They're not out there anymore. They're very transitory, and it's hard to find somebody that stays the course in a community or a clinic. And in a clinic situation, our medical system has gone to more PAs or nurse practitioners, and the clinics have an overseeing doctor because they're easier to get one doctor than to get 5 doctors, and it's easier to get PAs if there is such a thing as ease anymore. And those are transitory too. If they like it, they stay. And the long term, when we get a pair of doctors into our system, husband and wife team, and it's more likely they stay if they are married doctors, but if one is not a doctor, they get away from the I-5 corridor or get away from the big cities that come here, and after a while, one of the other spouses gets bored with it. Not everybody likes the quietness and sereneness and going fishing and the relaxation. They don't understand the beauty that we see. And I'm with Lynn. I can't find any reason why someone wouldn't want to live here. It's a great quality of life. We have good schools. We have a lot of good stuff going on. Finally, an answer. A real one.
I don't have an answer. I actually have a couple questions, and I just want to toss this out there to those in attendance. A moment ago, Jan asked a question about Seymour, and I heard a couple comments from the audience of a couple sighs, deep breaths, etc. And as a county commissioner, I don't have the authority, but I can be your voice. And I'd like to know if there's issues at Seymour, what those issues are, and you know, it's not going to help if there are issues at Seymour now by adding more people from community hospital to come out. And I've heard other people say that they have a doctor that they see at Seymour. They like it. I've had other people tell me that the wait is long. They have, you know, between 25 and 30 clinics in the state of Washington, and they do have specialists. If you need behavioral health, well, you'd have to go to Aberdeen for that at Seymour. But you know, years ago, people used to think that Seymour was simply for the lower income individuals or for homeless, and that's not the case. I can tell you that as a commissioner, we do also serve as your county's Board of Health. We do have issues getting people to this rural community for employment when we need a DMHP for psychological care, psychiatrists or psychologists, SUD specialists that help with drug addiction. It's challenging to get people to come to Grace Harbor and be off the grid, so to speak, from the I-5 corridor. So I'd like to know what we can do to make that better, and if there was a way that the Harbor Regional Health Community Hospital and the county could collaborate with Seymour to make that better. But I don't know specifically what the issues are, but I'm interested in learning what the issues are.
Okay, we'll answer that question after we have a few more. I do have a person here that has some extra knowledge about that. So keep that in mind, and we'll go on to the next one. I looked at the webpage, and it's a good webpage, Harbor Regional Health Care. It shows family medical care in Aberdeen, Hoquiam, and Montesano. Montesano in 2020 had approximately 4,200 people. I don't know what there is now. And I'm wondering how a partnership with Montesano might differ than a partnership with us when we are close to 7,000 and growing, and we may be over 7,000 by now.
I don't know if I can answer that question because the clinic has been in existence for years.
It is. In my former occupation, I did insurance and risk, so I know that the clinic in Montesano has been there way before the hospital district was created, before the district came to be. Used to be under Grace Harbor Medical or Grace Harbor Physician Services, and now they have what is your
Harbor Regional.
no, who's your clinics under? They're a subsidiary. They're not of the hospital. They're a subsidiary of the parent company, and so it's a little bit different. And staffing is also an issue. My father-in-law goes to the Montesano Clinic. He used to see two different doctors. Saw Dr. I can't remember his name. And then he saw Dr. Tro, and they both have become hospitalists, as Lynn mentioned. And so that makes it challenging. But those, I don't think that there is a difference in the community size. I can tell you that there was discussion about Montesano leaving the hospital district to go to a different hospital district, to go to District 1. That ended up not moving forward, and they realized that what they have there in Montesano with that clinic, it has worked well. But that clinic's been there for 2005, 2006, if not before that. And I would say that it's been under the Grace Harbor Physicians, it's called something.
It's HMG, Harvard Medical Group.
Harbor Medical Group, that is what it's called. It's been under them for the last several years, and previous to that, that clinic existed. To say that I don't see a reason why you couldn't have a clinic out here, but you run into the problem that Commissioner Bruce said, is that you've got to be able to get people to come here. That's probably, I'm going to venture a guess that that's probably what some of the issue with Seymour is that they don't have physicians here. Are they using locums? I'm assuming that they're using locums that just are like traveling nurses?
And I talked with I spoke with Christy, who is the medical administrator over there, and she said that currently they have a physician, and she knows that it has been hard for them to retain physicians that have been, coming in and out. And as we were talking about, we unfortunately don't have the luxury of having a physician. Like, I grew up in a small town, and we went to the same doctor until he retired or passed away, but neither here nor there. And they are working on getting another physician to come in, so they'll have another one coming in. And as Vicki said, unfortunately, they don't have the behavioral health out here. They do have room for it, but they can't get a practitioner. And they do have the dental clinic, and I'm looking for my notes, but I'm trying to go off of what I remember. But what she was saying is there is room in there, and that they would be open to partnering with Harbor Regional Health, but we'd have to figure out what that was. And that she would be interested in talking with us, and of course Hashim would be interested in talking with us and all of you to see what it is that would be needed. So I am anxious to hear what you have to share after we're done with the questions.
All right.
Sorry. Oh, sorry.
Also, I want to point out there's other physicians in Montesano besides our clinic. And the clinic that we run is that we have physician's assistants or nurse practitioners that are there, and then they're overseen by our chief medical officer, Dr. Wong, that goes out and oversees that practice.
And we started some residency programs for medical assistants. So we're getting medical assistants from the hospital, and they come in and do a residency with us. So we train them. I mean, you get out of school, but you don't have that hands-on experience. So we've got the residency program for the medical assistants. And unfortunately, the next grads, now that they're starting the program up again, they won't come out until 2023. So we'll have new medical assistant grads, and we already have some applications from nurses who are going to be graduating from Grace Harbor College who want to do a residency program with us. And oftentimes we can retain them, so they want to work in the harbor, and that's what we're hoping for too. But we're trying to partner. We're also starting to go out with to the high schools and try to encourage them to go into nursing.
We've had some questions about that, and we would really appreciate more in the high school system, and let these people, young people, know that there is a future out there for them, and a much needed future. Again, I just try to clarify a little bit. If Montesano is part of the regional hospital, so there are funds that come from the hospital that pay for the Montesano, or is it paying for itself?
The hospital, if you look at our balance sheet, we have the hospital on one side and our Harbor Medical Group's on the other. It's part of Harbor Medical Group, which comes under our umbrella. Okay.
But it's self-sustaining.
We hope so. We hope it's self-sustaining. I lost my train of thought. Big word.
Where you were going.
All getting more mature.
Now we need memory care.
Memory does. Okay.
I'm not there yet.
Okay.
I'm not going there.
All right. One question we have is the fact that we do know, and everyone's admitted, that the hospital is losing a lot of money. Is there a future plan that looks forward that says this will end, and is it, what happens? You're losing so much money every month that at some point, is there an end to this hospital? Is there someplace else that you're looking?
Okay, generally speaking, I'm going to go back a little bit and give you a short history lesson. It's not because you need it. I just want to bring you up to date. Is that the hospital has been in dire straits for at least 10 years. And since the harbor, we've lost our timber industry, the largest part of it, and our different manufacturers have had fully paid insurance plans that people use the hospital and the doctors. That's what they got by for years. And as our economy has shrunk, as far as the type of insurances were available, our payer mix has changed at the hospital. 82% of the people that come to our hospital are Medicare and Medicaid, charity care, and so forth, where we get portions of on the dollar. And
Representative Chapman, when he was here in December, when we were speaking with him, we get about 63 cents on dollar for medical care for these patients.
And so, this happened right before I got on the board, but our bondholders were concerned that we might default at some point, not be able to pay our bond. So they forced a group called Navigant upon the hospital that we brought in, and we were required to pay for them, to look at our hospital and our finances and try to improve the bottom line financially, totally. We lost 100 employees over that. During that time, we scaled back to match our worker load with our clientele. I'm not using the word patient, but and that was part of it. CEO call, which was the second in command of the hospital, we didn't replace that position. There were several things happening at that time. And also they looked at all the other departments, and they found no problem with our leadership, no problem with our chief medical officer, our CNO, and some other things. They did recommend to us, which our commissioners did listen to, is the OB unit, babies are a loser for any hospital, because they take specialists and they're 24 hours a day, 7 days a week, right? And they said, well, you need to close your OB unit because it's losing money. We dug in and says, no, it's not going to happen. And so that's going to continue to lose money no matter what. And there's no way that, personally, I would feel good at night knowing that people had to go to Olympia to have a baby. So and that's one area, and some other areas they had us look at. Now, here's the good news. We were on track to be in the black that next year. Then we got the cyber ransom attack that froze our system up, and we continue to give quality care and prompt care to all our patients without any interruption, because we had to change from computers to handwritten everything until we got on board. And there was a cost involved in that whole thing. So we ended up at the end of the year not doing so well. And then everything's starting to get better, and then the pandemic hit us. So to look at the last few years, it's frustrating for us to say we were on track, had everything pared down, so everything was looking good into the future, and now we've been working with the pandemic problem. And when you look at our balance sheet month to month, it's hard to take it into, if you have to look at the total picture at the end of the year, the balance sheet, because, for instance, we can't generate any income when the governor says no more elective surgeries for 60 days or 90 days or 30 days. Yet the hospital's 24 hours a day, 7 days a week, we still staff it, we're still doing things, and that's how hospitals make their money. Through diagnostics, through laboratory, and through surgeries. It's not putting people in rooms, as I'm trying to say. It's not like a Holiday Inn. You get so much money a night. And so when they take away surgeries, there's no way we can make money. Now the good news is part of this, is that we've had COVID relief from the federal government, all hospitals have, and it's kept us afloat. And our balance sheet today is probably better than it's been for several years for cash on hand. And so we say what our plan is when we come out of the pandemic. Our plan is to have a full workforce and to keep generating funds, go back to where we when we were heading towards the black, because the infrastructure is still there for that. And the reason we show losses is because our inability to do the surgeries and so forth. And also, I want to stress once again is most people forget about pyramids. We can't charge a higher price for our widget that we make, or we can't cut a third shift at a plant to cut the bottom line, to improve the bottom line. We're still a trauma center that's open 24 hours a day, 7 days a week. And I think we're going to be fine. I mean, I'm not being hesitant because I don't think we are. It's because we've all said that all along. Is just things are moving in the right direction, we get kicked again. And I don't know how long this pandemic is. Are we going to have an endemic? Are we going to have another wave of something else? We don't know. But I assure you that we're going to have a hospital.
Thank you. You brought up a word that many of us hadn't heard of until very recently, and it's prompt care. And we did find it on your webpage, but I understand that when you go in the hospital, it's not very clear what prompt care is, or who benefits, or where it is. So would you like to explain some of that to us?
Absolutely. And I can only speak from when I got on the board since 2017. We've all talked about how do we improve our services. At one time before we had the new expansion to our ER, we did have an urgent care type of situation there. I know that for a fact because I used it for a doctor for the first 2 years I moved to the harbor. I didn't have one, so I went there. It wasn't really a moneymaker for the hospital. I'm talking historically because I haven't really dug into it. But they needed that property when they expanded our ER. So that's why it went away when they expanded the ER. Now the prompt care is something that we tried to institute working toward urgent care type of a situation. But we began this thought and the process at our East Campus before COVID hit. And the word prompt care was people that was in our system, within our system, already seeing our doctors, and they would call up and they need to be seen for an immediate problem, but they couldn't get in. So we had prompt care. You had to be in our system or using our services to be able to use prompt care. Then when the pandemic hit, our prompt care morphed into a respiratory clinic. So many people were having respiratory problems, walk-in respiratory problems, so it's a respiratory clinic. And right now, we're transitioning between a respiratory clinic and prompt care. But our plan was moving forward to open it up to the public, but to be able to open it up, we have to have more providers to be able to do that. So right now, the way it works is that if you're in our system seeing one of our doctors at one of our clinics, and you need to be seen, you can call up at 8 o'clock in the morning, and they're going to find a spot for you that day to get in. Now, that's the way it is now, but the plan is, as we move forward in the future, to make it open to anybody to walk in to it. And prompt care, urgent care, walk-in clinic, they're all the same thing. It's just whatever word you want to use. It's just that we couldn't handle the influx if everyone came to it. We don't have the providers to be able to do that. We want to get there.
Thank you for that. That does help a little bit here. I think what you're talking about, the urgent care and walk-in, is what many of us were aiming for here. It's not necessarily full overnight service, but if I break my finger, and where do I go? I have to go 30 minutes, 40 minutes, and wait in line. And I think that's what we're looking for here. And the reason Seymour was brought up is that it does have room and space that is not being used, and it is functional. It could be used for that. I think many of us would like further discussions between the hospital, Mr. Jensen, and Seymour, and to see where us citizens, what it would cost us per tax. Now, again, we're paying a tax to the hospital district. Okay. If we open something here, can any of those funds be diverted here on an annual basis?
I can only answer from the fact that I know that all the tax dollars collected go for the daily operation of the hospital. The daily operation of the hospital goes to pay down the debt service for the bond. That's my understanding. It's not like the money is collected from you and put into the hospital fund to be able to use. And I can't answer that definitively, but if the clinic was going to open up in Westport, there's no way that I could attach or ask to have the tax dollars for Westport attached to that, because the levy that when the district was formed on the ballot, it was to fund the level 3 trauma centers, the hospital. I mean, so that's the way the funds have to be used. Another question about the difference between urgent care, prompt care, and what we'd like to see, what you would like to see, what we'd like to see in your community, is there's so many groups in Ocean Shores that meet, not collectively, but at different times, different days, and so forth. It could be the same people that go to different groups, but they all have the same questions and so forth. But to work through this whole process, you have to work with your city government and have a point person bring this all together, these different groups with a common purpose. Even when you look at grants, you have to be more specific. And I'm not so sure how you're in your community, how you survey your people to figure that out. And the other reason why we continue not to have the best bottom line as a hospital is so many people that live in our county that don't use our services, that choose to drive by the hospital. And I want to use this opportunity to bring out the difference between Summit Pacific and our hospital. Is we have 19 beds in our ER, in our emergency department, 19 beds. We have one doctor. And I don't know how many nurses are staffed, but it depends on, because they pull them from different floors if they need them and so forth. I'm not into the staffing part of it. And so if I sprain my ankle severely, it's black and blue and swelling, and I think it's broken, and I go to the ER, I'm going to have to wait a while depending how many people are ahead of me. Because if you do it mathematically in your head, and I'm just using common sense, and I'm using this as a true example, but only the doctor can write, he can ask for diagnostic reports, only the doctor can prescribe medication and so forth, and if he has to go to this room, and this room, and you're the 6th, 7th room, it's going to be some time for you to wait. The other thing that I want to point out is that we don't have the homeless population in Aberdeen that get on the bus to go to Summit for their medical problems. They tend to come to our ER and use our ED as their primary doctor. And they don't come, one, they could have a whole sick family. They could have 3 kids with them. And so they got this room, this room, this room. And so I agree with you that when people go up to the ED that they have a wait time. Some people leave without being seen. But I guarantee you that we don't divert anybody in an ambulance that has a trauma. And we see everybody as quickly as we can. And when somebody comes in, it's up to the front end people to decide. If you come in with chest pains, a lack of breath, bleeding, a chainsaw accident or something, of course you're going to move ahead of the line. But what I'm just saying is that in our ED department, some people don't want to come to us, they go to the Summit. Well, I believe Summit has 4 rooms, so it depends on how many people are ahead of you is your wait time at Summit as well. And I know that wasn't the question, but I just want to point out, because a lot of people say that's the reason why I don't go to the ED. The other comment I've heard made is that if we had not an emergency clinic, an urgent care here, that our ambulances wouldn't have to make as many trips to the hospital. I hope don't fall for that misnomer, because I guarantee you the doctor's office we have in Westport has transports out of their office. It'll actually probably increase your transports, because most people know when they have a serious accident to head to the hospital, not the urgent care. And they call them walk-in clinics on purpose, because people are walking in with basic needs like colds and a sprain or a simple break or so forth. But there's no way urgent care can handle a compound fracture or a stroke or a major fall and so forth. And even if you have that in your community, your ambulance service is still going to be transporting those people to the hospital. I just don't want anybody to think that would actually cut down on anything, and because that's not necessarily true.
You brought up a subject, ambulance service in Westport. Is that through the fire department, or do you have an ambulance service that is private?
Finally, a question I'm authority on. I was part of the committee that organized the RFA in the South Beach. Started that when I was mayor. I've been involved with emergency preparedness all the time since I've lived here, and I've worked with. And I want to say this before I forget. You have one of the finest fire EMS services here too, and police department. You have good people here. The RFA was formed on the South Beach to save money, because everybody had their own fire truck, and when they were decommissioned because of age, they'd have to buy a new one. Well, we're so close out there, it got to be kind of ridiculous for everybody buying new fire trucks. So that was part of it, and we also have a highly trained, Westport had a highly trained staff, where the other ones would have primarily volunteers. And so South Beach Ambulance began out of the Westport Fire Department. And we worked forever to have a staff that was highly trained on the whole South Beach. And so when Westport would end up usually the first out, because we always had people in our fire department, where the other ones were all volunteers to get toned out. They didn't have people so we were always the first one to the scene, no matter if it was in Acosta or Grayland or wherever the fire was. And when the volunteers were to show up, they weren't as well trained. So by forming this RFA, we've saved our area a few dollars in the long run. And we also have a hired trained staff for the whole community. And I believe we have 3 ambulances, and we have one that's being retrofitted, so there'll be like 3.5 or 4. I mean, there'll be one that's used probably until they sell it. But, and they have, gosh, I had this in my other card, I've written it down. We have, I believe, 9 fully trained firefighters in the RFA, and then we have a slew of volunteers, I think 22 volunteers. They're still trained, but they're not part of the union part of it, where they're paramedics and EMTs, okay? So we have more. And last time I looked, there was 21 firefighters in Ocean Shores, and I don't know if they're all trained as EMTs or paramedics or what, I just don't know as far as that, but there's a lot more firefighters here in your community. And you have a lot more houses too. You know, it's a lot bigger community.
All right, thank you. PJ, did you want to make a comment, and then we'll finish with your comments?
Thank you. Hi, I'm PJ Faria, and I'm part of the group that meets every Wednesday, and it has been our hot button to discuss this need here in our community. So just a couple of comments, not needing to go too far into the weeds. In regards to Seymour, we had the luxury of meeting with someone who had experience there, and I have had personal experience there too. I know a number of us have had some very good experiences, and then we've had some negatives, and you're going to find that everywhere. I come from a huge marketing background, so that's not even a question. But I also know that Seymour has a number of locations that are quite positive. Apparently Vancouver, and then all the way north. There's a number of clinics that have really great positive relations with their patients and so forth. The commentary that was shared with us is that probably the staffing here is really overwhelmed, sadly, with so much work that they need to do, and then maybe some of the processes have become quite elongated in the intake area. So I just wanted to throw that your way. It's not meant to be a negative to Seymour, because I'm sure they're doing whatever it is they need to do and how they need to do it, and I'm sure they're very good people who are trying their best. But what I would say is, if that's something that you all do any type of investigatory work on, it would be wonderful if you could also maybe have some conversations about some of the other clinics that are even, I think one is, if I recall, Mason County maybe. And, you know, apparently it's just the processes and things that make things for a smoother scenario. So that's excellent that you would please look into that for us. The other thing that I wanted to touch on was I'm aware that with the Quinaults, there is a building, an establishment, a care facility of some type going on in Aberdeen, and I think that's for mental health possibly, and drug behavior. I'm sorry.
Medical assisted treatment for substance abuse.
Okay. I think my point is that because the region here is so large, and we have not just the larger population right here in Ocean Shores, but if you go up the beach, you've got a lot of people who all would probably love to have some type of more centralized location. And I'm thinking maybe there's some way to look at Hogan's Corner, maybe further up, whatever. But I'm just thinking, is there some type of collaboration that could take place, or at least discussion with the Quinault folks, and see how can we all incorporate something where we would all benefit. I'm familiar with USDA loans and grants, and they certainly do have their requirements and so forth, but at the same point,
I think that part of their requirements, if you will, are populations that are in need, and we certainly are. We have our senior citizen population, we have our veterans of population, we do have our tribal populations. So there's quite a bit that I think can fulfill the package of what possibly this grant requirement would be. I'd like to ask a question about the grant. You mentioned, Michael, I believe, in regards to the grants, I hope it was you, but that once a grant background or package is established here as part of the city, let's just say hypothetically firefighting and or other needs here in the community, once that package is basically established, then we've laid the groundwork for who are we as a community, what do we have. Did I understand that correctly?
You have the general idea of what I was trying to say. Now, some grants will require specific information and maybe different than others, but it's called a boilerplate. But also, when you fill these grants specifically for medical care, in a remote area, which Ocean Shores is, they will want to know what services are available, and that will list Seymour because they have to be in their community. It will list our hospital and our clinics that are 20 minutes away and so forth. I don't want to give you the idea that grant money isn't available. I just don't have the answer of what grants they would be, whether it's CSDA or a federal grant. But I will say this, from my knowledge, in working with different organizations, if there's a way to get the tribal entity interested in doing that, it'll happen pretty quickly because they have other funding mechanisms, federal funding and so forth that you and I don't have. And I'm not deflecting that away from the hospital, but I'm saying we have a clinic just south of Westport. It's a really nice clinic, and its name is Tribe. That's built, and their tribe, I think the census is 220. But their clinic serves everybody on the South Beach, that would like to go there. So they give preferential treatment because they're paying for it to their tribal members. But I'm saying there's so many things, everything's on the table in this community. So let's not discard anything. But I'm saying for us, when we discussed it, even privately, the health commissioner with Tom, or publicly with all of us, is that one of the easiest things for us to do is if Seymour wanted to work with us. Now, that doesn't mean they would partner with us and be part of our group. That means they would rent a space of what they weren't using. And that's what Tom was. But once again, that's still in discussion phases, and I don't know if Seymour will ever make that decision. So that's why that came up about us.
Okay, thank you for that.
Looking at something, because they already have an X-ray machine there. They already have a lab. They have all the things that would be required.
Right, and that does make a lot of sense. In regards to the prompt care, I'd like you to know, just as an FYI, one of my caretakers is in that building on the 4th floor, and we happened to be there the other day. And until you get in the elevator and see the 4th floor, that's when you see the words prompt care. And then also outside in the lobby, it just says, this is not an emergency room, but it doesn't say anything about prompt care. So I don't know how anybody knows, but...
And actually, on a call last week, I brought that up to CEO Jensen, and I said, there's no signage over there. It's on the directory board, but like you said, until you get in there, you don't know where prompt care is. So he was going to put that in the place that we, share it with our person who would be able to do that for us. And signage would be important. So thank you for that, and we had heard that. So thank you for pointing that out because I didn't realize it.
Sure, thank you. And one more last thought I have. Oh, sorry.
The other reason prompt care, just a little aside, was created was also to take the patients from the ED who were there who didn't need emergency care, and we could shift them over to prompt care. But as you said, that was interrupted by the pandemic. But that was another reason we did that, was to take the patients that really shouldn't be sitting there waiting and triage them and say, you know what, we can get you in over prompt care, let's move you. So that was one of the original ideas I heard behind prompt care as well. So if we could get back to that, that would be helpful to help that bottleneck in the ED.
Perfect, thank you for that. And my last point is strictly regarding the foundation for the hospital. My question is, my background is through nonprofits also, and so my question is there a scenario to umbrella, if you will, the foundation and then having something that is, let's say, nonprofit? Because we know when you start a clinic, it takes 2 years at least to have any kind of financial gain, if you will, but probably not. And just to see if there's some element of that we could somehow shift under or have as our umbrella. Thank you.
So I used to be on the foundation board, so I'm on the foundation board, but I'm going to answer the question.
Yeah, and I'm just learning.
A lot of the funds that we have as part of the foundation are endowments, and they're restricted funds. They can only be used for certain things, or we can only use the interest that are derived from those funds. And so I can't answer that question. It's never come up before, and I don't know if there are funds for startup funds or would be available. But I also want to. I know that probably the fourth time I've said this. Whatever we do has to be sustainable, and I'm not so sure in a grant process how we prove that, because I just don't know. I don't have an answer for that. But you'll have to have numbers. I mean, you can say we have an aging population, or people that retire here, or you can say how many people that live here, or so forth. But how many people will actually use the services? And one of the things, Elizabeth, that runs our HMG in our East Campus and coordinates our clinics, has said over and over again, when you start talking about how many people they have to have every day that it's open to even break even, it's an important number. And I can't give you that number unless we know what the size of the facilities are and how many people you have. Now, I don't want us to leave here today thinking that we won't help you with some of these things from the hospital side. And Tom would have some more information on the ways to look for grants and things to do. But the key to this whole plan is the having the providers. Because if you had a building right now in town fully equipped, and you called us up saying, we have this building, HRH, I want you to help us put people in there, we don't have anybody to move. We have so many vacancies within our system and our clinics and so forth, from the top to the bottom. And we don't see too much relief in that in the next 4 years. I don't know if anybody saw the 60 Minutes thing 2 weeks ago about hospitals. You hear this every night in the news about hospitals being short and people overwhelmed by illness and so forth. But if we start today, it still takes 4, 6, or 8 years, depending on which profession we're talking about, to get them trained. And we don't have as many coming into the professions as there used to be either. So there's just not one solution is what I want to get at.
I know another idea that was tossed around, and it was, pre-COVID as well. There was a group that met in the senior center, I think. And I was there, and they had somebody there from like the Veterans Association, or somebody who was representing the veterans. And we talked about a mobile unit. You know, would that be a possibility to have a mobile unit out here? And I think that sounds like a good idea, but I'm not sure what it will do, because I still think it's not going to meet the needs that I hear that you're asking for. So I'm not sure the mobile unit, is the right thing for what you're thinking. And I know that idea was being tossed around at one point in time, and we've even talked about it as commissioners, would a mobile unit work? And then we could move it, but yet if it's not your urgent care or prompt care, it's not going to solve that problem. So we'll have to figure out what possibilities exist. Do you know of people in the community that are here that would work in an urgent care?
Yes, Mr.
Yes, we have been talking, and some have come in and talked to us about it. I'd like to close this off now and maybe take 2 questions from the audience, and have them nice questions, and 2 or 3. Okay, gentleman right here to the left. You.
We've talked earlier, people have talked about the expense of the traveling nurses. Has the hospital looked at coming up with some kind of a creative benefit for retaining non-traveling nurses? Maybe you give them, you increase their pay. Is that being less than what you're paying a traveling nurse? Do you maybe, look, we're going to give you for 5 years, we'll give you a housing allowance of X dollars a month, something creative that will allow you to retain people without having to pay the traveling wage. So if you can, go ahead, I got one second for that, I'll throw that there.
So the answer to that is we do have sign-on bonuses, and we pay the same as most hospitals pay. And we could take, I'm just throwing this figure out, but we could take a nurse that makes $75,000 a year, and they go out and be a traveler to make $240,000. We have nurses, especially nurses that come into our system that cost in excess of $125 to $140 an hour. But we have to have them. We're a level 3 trauma center. And so when we have people ask us, how come you guys are bleeding money? Oh, I didn't mean to use that word. How come you guys are losing money? Is that we're paying one person. We could have 3 or 4 nurses working. And so, but I become personally frustrated, even though that I've been in this public realm for many years, is that when I present the facts, people say, well, those are excuses. No, that is the absolute truth. And I know this isn't a question, but I want to morph to divert, the question about divert, and because it comes up often. Our hospital doesn't decide to go on divert. What our EMS does is hold their thumb on the pulse, I'm doing that again now, of all our hospitals and knowing how many rooms we have available and how much occupancy is in the ER and so forth, and they coordinate with all of us. And then EMS, when they tone out to your fire department or ambulance service, they tell you where to take your patient. And if it's a trauma patient, it always goes to us. And sometimes they get airlifted to Seattle or whatever, depending on the trauma. But they don't ride in a bus all the way to Olympia to figure out what their problem is. So we get the trauma people. But I'll tell you, it's been so crazy this year because of the pandemic, because of the lack of staffing in all the hospitals. There have been days that we've been on divert, someone's been on divert, Providence and Olympia has been on divert. So our patients end up in Tacoma. Doesn't matter whether you come Pacific Beach, Coquitlam, Westport. And so it's all about staffing, but we offer incentive packages to doctors that come to our area that may have student debt. All hospitals do that because you couldn't get doctors unless you do what other hospitals are doing. And the same thing about nurses, we have sign-on bonuses. I know this year Tom had given all of our nurses a longevity check for thanks you for hanging in there to keep people. And then the other extension is, if we paid all our nurses double what anybody else, you think you'd get more nurses? Well, do you think that's going to help our bottom line? See what I'm saying? When we're paying twice as many. So there's more. What I'm saying, I'll make it a little bit simpler. If we're paying more, if we have a problem with profitability at the rates that we pay now, and if we were to pay double, that's not going to improve our bottom line necessarily. That's all I'm saying is we pay more. So whatever you offer them when they're hired is that you're there going to be paying that for as long as they are. It can't be temporary. So we can, and I can't speak for Tom Jensen, but Tom explained to me that we do have sign-on bonuses, and so that you need to know that it's just not like going to work for McDonald's where you get minimum wage and that's it. So yes, sir.
The second part, you talked about divert a couple of times, and unfortunately, the last few years, we've had several structures burned to the ground, and we've actually had loss of life here because our fire department tells us when they're transporting people, they're told they have to keep on going, which leaves us without first responder care here, which has literally cost us structures and cost us lives here. And to most of the residents of Ocean Shores, that's not acceptable. How does that get fixed?
There's two ways I can answer that question. I'm going to do it the simple way. As cities, we have all mutual aid agreements. We have interlocal agreements between cities, the loan equipment and so forth. When it comes to the fire and medical services, we have what's called mutual aid. When somebody's toned out, somebody else is toned to cover your city. And in general, I can't say specifically how it works, but I know Dr. Black can explain it. I heard she's going to come up to one of these groups, the VMS. But I can use Westport, for instance. Let's say we have 2 ambulances on transport. We would call Aberdeen, and then they would send South Aberdeen out to cover for us, or they would be on tap. So even though Hope William probably is the closest one to here, there's always going to be somebody that's going to be backup. Now, are they going to drive out here and stand by? I can't answer that question because I've been too far away from that process to answer that. But I'm sorry that you've lost life, that people lost their lives in fires or EMS or whatever. But it's almost impossible for us to. I can't speak for the hospital about this, but for us to try to guess who's going to be in an automobile accident, who's going to have a fire, and who's going to be in our ED all at the same time. And so I can't answer that question generically of how it's going to happen. The only way that the diverts will slow down is when we have enough personnel in all our hospitals. And I want to go one step further. You have deficiencies, you could probably hire more people here as well. I don't know if they have funding for that. You might have it all fully funded. But everybody I've talked to, even on the South Beach, we can't get paramedics trained either. And you can talk to Aberdeen, Hope William, and they could use more paramedics too, and more EMTs. So it's not just the hospital, it's the medical profession. And I don't know if that's going to solve the problem, but I also want to say one other thing, and I'll hand it to Vicki, is when I put myself in your seat, sitting out there, it says, well, you're not telling us how we're going to get it and when it's going to happen. Because I don't have that answer, but I feel the same way that you do in Westport, is what I'm trying to say, is I have the very same issue. We're actually a little bit further from services. We have some stoplights and so forth to get there that you don't. But I don't ever want to say that we have similar problems and so forth. But we do hear you, and we would like to help, and I just don't have an answer of how quickly that's going to happen and how it's going to happen.
I'm very sorry that you had loss of life and also property as well. We don't like to see that occur anywhere. As you may have heard in the last couple of newspapers, Cosmopolis, where I live, is dealing with their own issues with the fire department. We do have mutual aid, and Ocean Shores should have mutual aid. I would talk to your city representatives as far as transports, if they're taking transports that are their own people, and who covers when they're gone, whether that's Fire District 7, Fire District 8, or Hope Wim. I know we have an agreement. I serve on the 911 board, and we have an agreement that Ocean Shores covers for the casino during certain times of the day, and then Fire District 7 covers in certain times of the day. So I make sure that there's a level of awareness there. One of the things that wasn't brought up, I know that Michael mentioned that we might have homeless people that go up to the hospital. One of the things that I'm working on is the mental health issue. We can have someone that is in crisis go up to the emergency department, and I kid you not, they could be there 10 days, 30 days, 45 days, 75 days, because there's no bed for them anywhere. And I can tell you that the hospital is not getting paid for that. That's part of their, what did you call it? Your charity care. They may have DSHS, but again, your payer mix, and you'll hear that term from Mr. Jensen, your payer mix is different. I think that there are a lot of issues. It's been very enlightening for me to hear a lot of the comments today on where we stand and great improvement. I can also tell you that when you talk about, you can't really compare medical staff to other staff, but we're seeing a shortage of staffing throughout the county, not just our health department, those that work in the health division, but other areas of the county of getting qualified staff to do specific jobs. I've spoken with Tom Jensen for, I think our first conversation was in 2015 or 16 about getting a single bed certification for mental health beds, and we're working with them on that right now. and being able to use some of the monies that the healthcare authority has specific to that. It comes from a specific pot of money to be able to use that. So there is work being done. It isn't fast, and a lot of it has to do with the lack of bodies that we have to be able to fill some of those positions.
I'm sorry, one last thing really quick. I'm old enough, for Vicki, this is the same conversation. I'm old enough to remember back in the day when the state of Washington actually provided mental health services that hospitals could refer patients to that needed mental health work. Does anybody have any idea if the state will ever get back in that business?
Well, the state...
Or if you're funding that business on some level?
That's a good question. One of the conversations that I had back with Tom several years ago, and it's been ongoing, is the lack of mental health beds. And they do take up space. That if you have two mental health beds or 3 mental health beds, and you can't bring in someone else, they've got to divert them someplace else. That's a problem. I can tell you that when the initial conversation came about, at that point in time, Steve Theringer, Representative Theringer, was working with other state legislators to look at removing from western and eastern states some of the civil commitments. And the civil commitments are nonviolent. A lot of them are elderly. And I suggested they want them to have more community-based care, so they would go into a local hospital or facility here. And we have a number of beds that aren't being used currently at Harbor Regional Health Community Hospital. And my thought was, why can't we use those beds? The state then would pay for the beds. You could say, yeah, we're going to give you, they work off of the angle of 16 beds. That's where, if it's less than 16, it's not real profitable. If it's more than 16, it's more costly because you have to have more staff. It's why we have a 16-bed unit for involuntary treatment up in McClary at the old Mark Reed Hospital. So there was a lot of confusion, and we were able to learn from the legislature that taking on those civil commitment beds does not impact their maximum bed loads to where they would lose some of that payer mix. But then the state decided to not go that route. And so we've talked about these options and tried to be able to fulfill some of the needs that we have locally on that level, and it's challenging. In the meeting that I had with Tom, Michael was there, Dr. Ann Wong, the chief of staff, was there at the time, and she brought up exactly what Michael was saying. Yeah, we could do the civil commitment beds, we could do the single bed certification, but we still have to have those DMHPs, the mental health professionals, to be able to work it. You can't have your surgeon working in the mental health ward or your pediatrics person doing that. And that's what has been challenging, is to get people here and to keep them here. I was in to see my doctor in January, and I've seen Dr. Bosher for over 30 years, and Dr. Bosher's in his mid-70s, and I'm praying he lives as long as Betty White, to be honest with you, or at least to get me through this. But that's some of the issues that we're having, is that Dr. Worth left in that office, and Dr. Bruce, as Lynn calls him, he retired, and we have a PA that came in, Nathan Valentine's a PA that came in. So you're seeing that changeover come about. But I will also tell you that paying off the debt for the hospitals to do that is huge. It really is huge, because you're having people not further their education due to cost. And that's really, really hard. And you're gonna get to the point that you're only gonna have a locum, you're only gonna have a traveling nurse or traveling doctor. And you're going to want to have a Dr. Bosher that I can go in and he can say, your cholesterol's up again. And I said, well, I'm eating oatmeal and trying my best. Well, you need to walk and stop the nightly bowls of ice cream. Okay, we're going to get to the point where we don't have that. We're going to go in and we're going to see Dr. Jones one day, and three months later, we're going to see Dr. Smith, and then 3 months later, we're going to see Dr. Johnson, and there isn't going to be that continuity, and it's because we can't keep people. It's already that way. I mean, my doctor, their office isn't taking new patients. I don't think the medical clinic where Dr. Strange and them are, they're also, and I'm not trying to be disrespectful, they're also aging. You know, if I could, I'd make Dr. Max come back to work, for those of you who remember Dr. Max. But it's a real hard spot to be in, and should the state be paying for it? Absolutely. Especially on those mental health, it should not drain the counties, and it should not drain the hospital.
The other interesting thing, sitting on the quality committee, you hear about the patients that are, you know, in beds, the mental patients and the behavioral health patients. And they require, if they happen to have restraints, they require what you'd call a sitter. So then you have to pay staff to sit in the room with them. You can't have a monitor. You can't have somebody looking on like a baby monitor. You have to pay people to sit there with them. And the other issue we have is the same thing. The beds get taken up with nursing home placements. We don't have enough beds to move those types of people into a, you know, skilled nursing facility because those beds aren't available.
Or they're harder to get at because of COVID. You got to wait that 14 days before
Then you have to hold them, and that's what was happening. We were holding them 14 to 21 days. You'd get them 14. If they still couldn't get a negative test, they were holding. And those are taking beds away from the patients that could come in through the ED. It's unbelievable. I've been in healthcare over years, and the changes I've seen, and as you said, Vicki, it's not, you know, we're not going to have those physicians forever, and you just can't have the same one, and it's not pretty. It's very scary out there. It's scary.
I got something I want to add about the ambulance issues. Is that when someone, doesn't matter what community they come from, Ocean Shores, Westport, Aberdeen, Hoquiam, the unincorporated area, when you transport a patient, and if that patient needs to be transported elsewhere, if it came from Ocean Shores, it'd be your ambulance that's asked to do that. And one thing that I've been working on as a commissioner, because I know some of the people involved in this, I went to the RFA. I just had lunch with the chief of the RFA last week, and I said, I said Chief Ben, but Dennis, and I said, is there any way that you would want to contract with the hospital for transporting patients that would help relieve the pressure of these other communities when we use an outside ambulance? And it's something you could buy an extra ambulance for and contract. And he says, Mayor Bruce, and I'm sorry he calls me that because I hired him, and he says, that would be something we'd be interested if we could find trained EMTs and paramedics. So we're right, it's the whole thing, dog's chasing his tail going around and around. So that's one thing that I'm working on, is trying to come up with an alternative for all of us, if we could use someone outside our system to do our transports instead of, and of course they'd be billed the same way that, you know, whoever transport the patient. So it wouldn't have, the only thing it would affect our communities in a positive way is that the ambulance from Ocean Shores will go back in service, the ambulance from Westport will go back in service, Aberdeen, Hoquiam, when you have someone else doing the transports that are needed from our community. So we are working on all the issues all at the same time. Now, we're going to have an answer for that next week? Probably not, but we're working on it. And I also want to say that we're always in constant improvement at the hospital. There's always something that seems to want to kick us in the shins. We have state-of-the-art mammography, and I don't know how many people know about it. We had a billboard. We have a state-of-the-art cath lab where people, you know, get their cardiac services done. Now, we don't do...
You can do stents.
Yeah, we can do stents, but we don't put in valves or heart transplants, stuff like that.
Right.
But you can surely go there for your cardiology appointments, and you can do your stress tests, and you can do your other things. Now, our plan is to add more services to that as the doctors become available. But there are things that we do at the hospital today that we didn't do 3 years ago, is what I'm trying to point out.
We have one more short question, hopefully short answers.
Mine is more of a comment. Have you ever thought of using, because you were saying that you're losing money and you need, or, having babies. Have you ever thought of using midwives? And then the other question is, you say you had the radiography equipment at Seymour and whatever. Our background is in radiography, industrial radiography, but radiography has changed in the past few years. You don't need a radiography doctor, what do you call those? Radiologist to interpret the radiographs sitting right there. You could send them digital. The last time I had my mammogram, the computer did the analysis. So, I mean, there is a lot of innovation that you could probably take care of your...
We have that here because I just had that same procedure done last month and it was very quick, very easy and digitally read, and I received a report probably like you did in the mail and thankfully was fine.
You can send radiographs to Seattle if you want to or whatever.
But I have a good friend of mine that worked at Grace Harbor Imaging that relocated, he relocated to South Dakota, but he still does work for Harbor Regional Health because he can do it digitally. So I agree with you. Being able to do those more and more is going to be very beneficial for the community in general.
You could do that probably with ultrasound and with probably some of this test tests. I don't know. I mean, radiography and ultrasound is what you did.
Good question.
So they're talking about mammography. You better go next.
Oh, why?
Someone's not going to 30 than me. Also, we have a bariatric center, a wound bariatric care at East Campus. What's it called? Bariatric. What's it called?
Wound care.
I guess it's just called wound care.
Yeah, I don't know. Bariatric has to do with weight loss.
Yeah, I'm not gonna, that's
Bariatric
chamber. So the answer about the midwifery, I don't know if that's even discussed. The only reason I brought that up about OBGYN or baby services is to give you an example of just because people come in and say cut it to be profitability, there are certain things that you can't do. Your community needs a place for people to have healthy babies. And so that was used as an example.
Midwives have been around forever.
I just want to comment, I know I'm not part of the hospital, and while I am a commissioner, I would like to stay in communication regarding these topics as we move forward. I think it's important, and so if I could continue to be included, I would appreciate it.
I know, I get the minutes, and the minutes have been very helpful, so if you could get on the distribution for the minutes from these meetings, that would help, and then we can keep you in the loop as well.
But I think we need to see, first and foremost, we need to chat. I'm not part of it, but I think there needs to be a conversation with Seymour and Harbor Regional Health to see what collaboration may fit well for this community.
The other thing that is on my list is I was in town yesterday and I was working, we own the Honda dealership, I'm just going to go past that. So I was working at the dealership and Tony Ensler came in, who is now over the Quinault group, is that what his title is? He's a manager at Quinault, and he wanted to see me, and my question to him is, how's he going to staff that big facility? That's my question, so I want to talk to him about that, and I'll share with him the conversations we've had here, and see if there's not something I can start some dialogue, but he did ask me to call him, so I have his card, I'll give him a call, but I want to know how they're going to staff that facility as well. Just curious, so I'll let you know.
And to tag on Vicki's comments, Vicki and I worked for so many years together, cooperatively, and worked on a lot of projects together for the betterment of our communities. And don't think that Vicki doesn't call me if one of you call her and she wants more information. We have a good relationship that way, and I'm not afraid to hear from any one of you either. I don't have any cards with me, but you get my information on the website. But the only reason why I'm here today, folks, is because I want to support Lynn, and it's not because I necessarily know more than her. I can give more to the background about grants and about how to work with cities and have these other things because I've been there, done that. And I think the takeaway from today is is I want you to collectively think about coming up with one project that would work the best, and making sure that you communicate this with your mayor and the city council, and get them on board, and then make sure that as meetings go forward, that we have a common voice and a common focus. Because we can't help with ideas for grant writing or focus on a project until we know exactly what the community would like to have. And if I were to make a recommendation is to get something and then expand on it as you go. And the only reason I brought up the tsunami readiness stuff is because it's topical. And of course, Acosta, the district I used to work for, was the model program for an evacuation out of school. And I know that Westport has been working on some kind of a tower situation. And I'm just thinking out of the box forward is if this community is in those type of conversations, I'm sure your elected officials are, is that maybe something to think about for federally funding a building or a structure that would help into the future. Not saying hospital district is divorcing ourselves from this conversation. I'm just saying that's another thing to look at. And also, and talking to the tribal members to see. And I think that Tom is, so here's how it works on the structure of the hospital. We're different than a city council. In a city council situation, they make all the decisions, they make all the rules, they pass the resolutions, they decide on the budget. The mayor presents the budget, and the councilmen go in and mark it all up and change the priorities. And then the council is the one that spends the money. The mayor can't spend the money. The mayor can give clarity or give ideas and talk to you about what his or her goals are. But really, your city council is in charge of the expenditures and so forth. In a hospital board situation, we hire a CEO. The CEO does all these things. We don't individually, as commissioners, sit down and talk about specific contracts, what wages are for our employees. The HR admin team does that, and so forth. It's quite much different than a city council. And so a lot of people that come to us with questions just assume that we do all the things like a city council or what county commissioners do. We don't. It's a different thing. And we have workshops, we work collectively, we have subcommittees, the quality committee, which Lynn sits on. I don't sit on any of the committees. The quality committee is 3 commissioners, because we have seven commission board. And then we have the finance committee, which is 3 commissioners. And the reason I don't sit on any committees is because I replace those, and then I'm also out in the public talking to other people, and I have meetings all the time, and I usually meet with the CEO when he meets with other people. And so forth. When we do, the Department of Health comes through and does a survey, or we do our annual certification through organizations. I sit on the credentialing committee and the accreditation committee. So I sit on the committees that hire the doctors or re-credential them. And I'm here to tell you, if a new doctor applies for credentials at the hospital, it will take 3 to 6 months before that doctor is fully vetted through the process. The only difference is if a doctor comes to your community, they're just licensed by the state and they can put their shingle up and they can start a practice. But when you work in a system like a hospital, they're vetted for the proper licenses, what their certifications are, if they haven't ever had lawsuits, anything that in their past never leaves a nurse or a doctor's jacket. You should need to know that. It's always a part of, it follows them around wherever they go. So I sit on those types of committees. So I just want you to know that we're a little bit different than the way the city council works, and it's ultimately important that our community and our community groups work with the city council for anything moving our city forward.
Okay.
We've got 2 more questions, and we'll make it real short.
Okay, so 90% of this meeting is not what I wanted to talk about. The intention of this meeting was to find the different paths that are available for our community to get the medical help it wants. All this other filler, that was great. It was great education as far as how you guys run your operation and what the problems are and how they're trying to be addressed, but it's not what I wanted to hear. We want our medical concerns taken care of, and they're not. And I wanted to talk about specific paths. Well, we could do it this way, or we could do it this way. We could talk to the Indians. We can get a grant. I wanted to talk about specific paths that we could follow and start to do our investigative homework So in 2 years from now, it might take that long. We might be building something here. So I think maybe we need to have another meeting and talk about those issues. What does Ocean Shores need to do to get its medical concerns taken care of? So that's going to be on the future. We're going to, because we're out of time now, and I want to get Rich up here, he has something to say. So that'll be another meeting, and hopefully I got the right people in there so we can talk about it. But I did hear a lot, and I know, everybody knows it's hard to find doctors and nurses. My wife's from the Philippines. Their biggest export is their people. They go out all around the world and work. And the most common person that leaves the Philippines with a job that's been given to them is their doctors and their nurses. They've got some of the best hospitals in Southeast Asia. And you can go all over Europe, you can go all over Asia, you can go to Canada, and you're going to see Filipinos, doctors and nurses. Why aren't you guys doing that? You can answer that.
Mayor Bruce.
Commissioner Bruce now.
Commissioner Bruce. Let's still call you Mayor. You have two city council people here now. It's not the city of Ocean Shore's job to take care of health care. We are out in the community doing our best to coordinate and to focus citizens on people that this is part of their responsibility. And I don't know if you intended it, but when you had said, we in this room need to go back to your city council to get them to get things focused up, that's not our job. Our job is to help and get people pointed in the right direction. And that's two of the three of you that are up there. This isn't Vicki's job either. But as she said, she wants to be involved just like Frank's here and is involved. We all know this is a lot of work. We all understand the pressure you folks are under. I was here a couple of weeks ago brainstorming, and I had suggested to this group, based on the hands that were raised, how many people in this room, if their fingers were cut off, would go to Grace Harbor Hospital for care. Not one person raised their hand. They said they would accelerate past the hospital rather than go to emergency there. That is not our fault as customers. You two didn't create the issue. Whether you want to agree that it is or isn't a problem, the perception is that it is a problem. So as a hospital board, I as a citizen and other folks, we would ask you to please focus on emergency to increase customer care and satisfaction, because we feel right now it's not at a level that the people in this room 2 weeks ago would ever stop there. The good news is the folks that were there was 4 people that had not positive stories about what happened in emergency, got transferred over into the main hospital. They couldn't have bragged more than they did about how fantastic the main hospital was. Care was first rate. That was so great to hear. So we're here today to say it's obvious Ocean Shores would like a clinic. We all understand it's about writing big checks to get it, because we even know past nurses or CNAs who are out here, we're not self-sustaining. They can't make a living out of it. Has to be subsidized from somebody somehow. Whether it's the hospital that just wants to make it a loser like the OBGYN, or the locals do it somehow, free rent, whatever. But I know what this group wants is care closer to home, but at worst, right now, they want an emergency room that they will slow down, turn left, and use. And we need you folks to work on that. It's not going to be Ocean Shore City Council. We want to help any way we can and encourage and communicate. But we want to put the weight on the 7 commissioners of the hospital district that were elected to work with your CEO. And as you know, the only thing you guys can do as 7 directors is give the CEO your walking orders as to what your priorities are as a group, and then hold that person accountable. As far as we know, Mr. Jensen is the best CEO in the world. We don't know any better. You guys know whether he's doing the things you're asking or not. But Ocean Shores wants a clinic. Kind of understand the money's not there yet, but at least they want an emergency room. That's what we've learned.
And thank you, Rich, for those. In the quality committee, every month we talk about the ED. So I will share exactly what you said and what the comments were from the community. And they are working on it diligently. And it is a major focus, but we have to work on that. But my frustration has also been when I spoke with somebody, it's like, well, we want a medical center. So that's like Summit. Well, then we want an urgent care. I just don't know what it is. We just need to know. I hear urgent care. So is that 24/7? If it is, you might not get that right away. I mean, if we can start getting in specialists over here to Seymour, is that going to be a start? It's just been frustrating. I don't know. We don't all know exactly what you want. So if we do work with Seymour to start getting some more physicians over there, that might not be your answer anyway. So is that a start? Is that somewhere we want to begin? I don't know. I don't hear, exactly what we need to start with and what will be helpful, because it might not be an urgent care to start with. We might have to crawl and get what we can get and get started, but then investigate how do you get to an urgent care if that is the bottom line. But we need some direction, because I've heard everything from a Summit to a urgent care to, and I don't know. But I've heard everything today. I have, and I will take it back, and I'll work with Michael and the team. And the ED will be a focus. It is, but it will continue to be until it gets fixed.
Well, again, I want to thank you for inviting me here today. I do want to comment to Mike that I actually reached out to Rich because I wasn't exactly sure what my responsibility was here today, but I do come with an open mind, and I do want to be your eyes and ears for this area. But Michael made a comment when we first came in, and you weren't up here when he made the comment. But Jan said we have some questions that we're going to ask. It's helpful if we have an agenda. It's helpful if we know what you're wanting to hear, what everyone else is wanting to hear. I didn't know what the format was other than to be able to ask questions, and I came to answer what I could and give perspective where I can. But it would be helpful if you want X, Y, and Z covered, let us know what that X, Y, and Z is. I don't mind. I can, in no time, I can bring you whatever you need to know on the health department, any information on mental health, substance abuse, all of that I have at my fingertips, and that's easy to do. But at this point, I think trying to find something collaborative with Seymour or something to at least get the ball rolling is going to be key. But if you reschedule this at a later date, I just want to be clear. I'll be here. You let me know when. I'll put it on my calendar, and I'll make it a point to be here. But I think all of us need to know what you want, what the end result or the outcome of the meeting is that you're looking for, because it's hard just to go off general questions that we get, because I thought we answered the questions that were posed to us, but it's obvious that some people, this isn't what they were looking at for this forum. And so I just don't want us to I don't want to waste your time or ours or anyone else's if we just could have an agenda and such.
And I hope this was educational, because I've learned
It was.
today, and I hope it was educational. Because my original thought was when we were talking back, with Tom and Michael, I said, well, let's plan it. Education is important too for all of us. And me hearing from all of you, but also you understanding where we're coming from and where we might go together. So you've heard what we're dealing with, and we know how you feel, so let's see where we go from here, and what do you really need and want.